talk about the congenital glaucoma, the other student is Dr. MANDAL. So he is one of the best surgeon for congenital glaucoma and is very senior leader and expert surgeon at LVPI. Over to you, sir.
Thank you. Can you present the video? Although this is a session of MIGS, I am presenting a surgical video on standard trabeculectomy without any antimetabolite. Can you present the video? This is the standard, gold standard technique. MIGS must be compared with standard glaucoma filtering surgery, that is trabeculectomy, because this is the gold standard against which any new procedure must be evaluated. What we are seeing here is the superior rectus traction suture is given. One can give corneal traction suture, and the eye surface should be washed thoroughly before we really incise the conjunctiva and the subsequent steps. Here I am showing limbus-based conjunctival flap. Tenons and conjunctiva is dissected in a single layer, and the dissection is carried out on each side. An incision will be given to incise the conjunctivo-tenon layer on each side of the entry point. The tenon's capsule is being dissected, and then the other side incision is given. The way I used to do the incision is the way it is seen here, about 6.5 millimeter from the limbus, just in front of the superior rectus insertion. Superficial cautery is done to really cauterize the episcleral blood vessels. Now, I give standard incision about half thickness scleral incision in a triangular fashion, and this is with the help of 11 number BP blade. With the help of limb forceps and 15 number BP blade, I am dissecting the sclera. Thickness will be 1/3 to half thickness sclera. In pediatric glaucoma, we used to make it relatively thicker superficial flap. In adult, it can be 1/3 thickness. The dissection is carried out anteriorly towards the limbus and is carried out just about 0.5 millimeter in front of the anteriorly into the corneal lamellae. Now, the anatomy of the limbal region should be carefully identified. With the help of a traction suture with tenonylon, the assistant used to put the finger over the retracted suture, and then 2 radial incisions are given just to delineate the area of trabecular meshwork or the subscleral tissue you want to remove, without entering the anterior chamber. This is just to delineate the area which you want to include. And the posterior incision will also be given, as you are seeing here, again superficial incision just to delineate the area of subscleral tissue you want to remove. Then a very pointed entry just to make sure that the anterior chamber is entered, and you can see the blade has been reversed so that it just inside the superficial wall, and then with the help of micro seizure, venous seizure, 2x2 or 3x2 millimeter limbal tissue is excised. You can see here the block is made and about to be removed just like that. One can use punch or the way the surgeon prefers, and you can see iodectomy should be done with base which is equal to or even little larger than the deeper block removed. In higher magnification, it will be showing here once again the way orientation should be, that the base of the iodectomy opening is wider than the apex. You can see the ocular pulse here. At this point of time, under higher magnification, you can see 2-3 ciliary process. And that's the end of trabeculectomy part and iodectomy part. and then the superficial scleral flap will be sutured back. The tenonylon suture. I used to do 3 sutures, one at the apex, one on each side of the triangular scleral flap sides, but because I do not believe in using mitomycin or 5-FU in primary surgery in all the cases, newly diagnosed case with moderate to severe degree of glaucoma, I did some experiment in my early years in the late 90s, and I felt that the good results can be obtained, intraocular pressure control can be obtained if we avoid side sutures. That is, one on each side suture can be avoided. One can argue that it can lead to overfiltration and shallow anterior chamber in the early postoperative period. Not really, because if you do the surgical technique, it is possible that chamber depth can be maintained even though there will be little shallowing, and as and when you are completing the suturing, that is apical suture, the chamber starts deepening, and the tenonylon suture is trimmed, and the knot must be buried inside the sclera. That's the way it is shown here. You cannot afford to put not to bury the suture, because it will lead to perforation of the conjunctiva, and in the postoperative period it can give rise to a tract which will invite infection from the surface. Endophthalmitis or blebitis or bleb infection can happen. The conjunctivotenon layer is repositioned as you can see here happening, and a continuous suturing is done to close the conjunctival tenon layer closure. So this suture is aetovehicle suture with a tapered needle, round-bodied needle. It is preferable because cutting suture should not be used. It will lead to multiple points of leakage in the suturing area. Permanent knot is given there, 3 single throw suture, and then with the help of a good needle holder, with your best control, suturing from one end to the other can be done with a continuous suture. And in the beginning you can do the suturing, say in the posterior inside out, then outside in the anterior it is inside out, and then outside in. In the posterior it is inside out, and then again outside in. That's the way entire length of the conjunctivotenon layer can be threaded. It requires little practice. It's like a closure of the subcuticular stitch we used to do for skin. And the entire suture, if in the beginning phase of surgery somebody can do in steps, no problem, but meticulous suturing should be done so that there should not be any gaping, and the suturing will end in watertight closure. And at the end, finally, one permanent knot will be given. You can see here, I am including the finer or the final stage of threading of the conjunctivotenon layer, and it will be closed. I do not use mitomycin, as I told you, in the most of the surgery. Even now, the surgery which you are seeing here was performed in the year 2001. This is about more than 24 years ago surgery. I still do this surgery in the same way. This is the surgery I saw my Professor N.N. Sood used to do, and I learned from him, and inspection should be done that the entire length of the conjunctivotenon layer incision is positioned very well, and a permanent knot will be given in the other side. You can see here. Now this is the end. You have seen I have not given any paracentesis opening. I have not done any I'll say flow of fluid, ringolactate or balanced salt solution in the anterior chamber. I personally believe minimal invasion or minimal manipulation, because in Indian eyes, iris pigmentation is such, the moment you will try to see the efficacy of the ostium, how it is filtering intraoperatively, will lead to release of pigments, etc., which will be causing more inflammation in the early postoperative period. The least manipulation, except the iridectomy and the final stage of trabeculectomy, I have not entered into the anterior chamber, and this is the standard appearance at the end of surgery. Now, the question is, in difficult situations, this is an isolated trabeculectomy. If I do combined trabeculotomy and combined trabeculectomy with cataract extraction, I do fornix-based incision, there limbus-based causes more manipulation and more problem. This is the end of the technique. At the end of the surgery, superior rectus suture is released, removed, and inspection is done so that we know the closure is good. Somebody may put a fluorescein drop, which I really do not prefer to spoil the surface by the fluorescein pigmentation. No parasitosis, no saline injection into the anterior chamber. I personally believe, stop here. I personally believe this is the way to go. If you are doing limbus-based flap and one can do little modification the way somebody wants, that's okay. This is the standard way I do, and I'm happy with my results. The only technique I have changed, suturing technique of the scleral flap from 3 suture to 1 suture. That's it. Thank you.